Last month we had a Zoom bomber who was renaming themselves to everybody, someone else's name, and then saying things in the chat. So I'm going to lock it down so people cannot rename themselves. And that should hopefully limit that from happening again. If we do have something similar, please bear with us. I will attempt to rid us of the Zoom bomber as quickly as possible.
Hey, Patrick, this is Andrew. Just wanted to test my audio and make sure you guys can hear me all right.
We can hear you, Andrew.
Perfect. Thank you.
Andrew, is Kurt joining us as well, or is it just you?
Yeah, Kurt's here. He's with me.
Okay.
Patrick, so Zoom still allows people to log in anonymously and that sort of thing?
It's easier when you do something that the offender was using Apple has like a fake email address, the temporary email address that they can generate for you. So that's what the person registered in with. I noticed that early on and suspected it was going to be a problem. But it was for some reason, Zoom allows you to rename yourself to someone else's name. And then when you clicked on the person's chat, it highlighted someone else entirely, which is one thing that triggered being a problem. Fortunately, I knew the person who, the first person they dropped an F-bomb with that person's name, has been attending these since the very beginning. So I knew it wasn't her. I knew something was up. Otherwise, that person would have gotten booted, which is probably what the offender wanted to do. So we'll give everybody just a couple more minutes to get in. Usually they join right at the last second. So we'll give them just a few minutes to join.
Hey guys, thanks a lot for doing all this. Really appreciate this.
Absolutely. Glad you could attend.
I got an email from somebody this afternoon. It looks interesting.
Okay, well, what was it interesting about?
You're asking me?
Yeah, you said you got an email that was interesting.
No, the topic of the presentation looks interesting.
Oh, okay.
I know lots of things about chromatin structure, DNA, RNA, Western blots, but I don't know how to recognize shock in somebody who's injured. So maybe you'll tell me. And I'd like to ask Mr. Portillo whether I get a free sandwich.
Well, you might get a certificate.
Well, there won't be any certificates for attending this presentation, unfortunately.
We can make our own.
Yeah. I had to take some training in nonviolent de-escalation and intervention. And they gave me this really plain, nothing certificate. So I made up my own. And on the bottom of it, I put restraint with dignity. I had the presenter sign it.
That's cool.
So this will be recorded and people who couldn't attend tonight will be able to view it.
Absolutely.
right?
It's actually being live streamed right now to YouTube. And once the presentation is completed, the YouTube presentation will stay up there. Eventually, we hope to edit these and make them a little more accessible, but you can send them to our YouTube channel. Just search for CERT coordinators in YouTube.
Okay.
Okay, I'm gonna mute everybody. All right, thank you everybody for attending tonight. This is our third Wednesday of the month, regularly scheduled Community Emergency Response Team Continuing Education Training. Every month we do these trainings in order to bring up beginner, intermediate, and advanced topics and really expand upon what's taught in the CERT curriculum, but also introduce new topics and more advanced topics that members who are more veteran can utilize in their programs. This is hosted by LA City CERT, but it is open to everyone. I know that we have people from Florida, I'm not sure where TIGGUARD is, but we have people from Texas, Washington, even Boston attending. Thank you everybody for attending. We have 105 so far participating. And without further ado, I'm gonna go ahead and turn this over to firefighter paramedic Andrew Huang, who will present.
Hey, how's it going, everyone? You guys can all hear me okay?
Yes, we can.
Sounds good. Just wanted to introduce myself for a second. My name is Andrew Huang. I am a firefighter with the city of Los Angeles, and I'm also a CERT instructor. And then I have Kurt Howard here with me as well.
I'm on the side over here. I don't know, the camera's weird.
Or just a hand. So I guess today we're going to be talking about patient assessment. Let me try to share this screen with you real quick. You guys can all see this okay?
Yes, go ahead and run the slideshow though. Let's see if it's the correct screen. Yep, there it is.
Perfect. Alrighty, so today we're going to be talking about patient assessment. We're going to be talking about a scene size up, what a primary assessment is, the medical portion of the patient assessment. We're going to be talking about a trauma assessment, and then we're going to talk about the triage and MCI portion as well. I think that's all why we're here, right? It's the triage, how do we treat patients when we have more than one, and how do we make sure that we give them the best care that we can. So we're going to be starting with our scene size up as our objectives, right? So scene size up is basically steps we take as first responders when approaching the scene of an emergency call, right? We use it to determine scene safety. We use it to determine PSI precautions. We note the mechanism of injury and then the nature of illness as well, the number of patients, and then we decide what, if any, additional resources we need, including paramedics if we need them on scene. So it's basically just an ongoing process throughout the call, right? Emergencies are dynamic, they change and they can grow. And as they grow and get bigger, we as first responders, we as CERT volunteers can grow and help assist that primary objective as well. It's important to know that when you conduct a scene size up, you always do your own, right? Even if someone's already done it for you, or even if it's already been done, a scene size up is basically just for you. It's for you to know and for you to utilize. Just because it's been done, don't assume that it's safe. So you just always want to make sure that you take care of it yourself. So going on into BSI. BSI is basically just the body substance isolation, right? It's what we take precaution with, is how we make sure that we're safe, right? We want to make sure that we have gloves on. We want to make sure we have either our masks on, N95, we have goggles, we have safety goggles, glasses. You wear closed-toed shoes, steel-toed boots work well, and then make sure you wear pants. Never want to wear shorts to an incident. And then scene size up, right? Elements of scene safety. So basically, what's the most important thing about scene size up and scene safety is that you want to protect bystanders, right? You want to protect them and prevent them from becoming patients. You want to prevent ourselves from becoming patients. You never want to enter an unsafe scene. We always stress scene safety, right? We're never going to put you in a dangerous situation, and likewise, you should never put yourself in a dangerous situation. If you go to the call, or if you get activated and you meet up with the crew and the area you're in is not safe, make that scene safe by either contacting your team leader, the person in charge, the incident commander, or call 911 if it hasn't been established yet, if you're the first one there. So what makes up the scene size up, right? You want to evaluate the scene for safety hazards. We're always going to stress safety, safety, safety. You want to take the necessary standard precautions. You want to determine the mechanism of injury versus the nature of illness. Take account the number of patients and then the need for additional resources, right? These are just basic ideas and basic steps that you want to keep in mind when you're conducting a scene size up. So in the fire service, we use a mnemonic called PENMAN, right? To assess our scene safety. PENMAN, for P, we're going to be talking about our personal partner and patient safety. You always want to make sure that you're safe, right? We don't want to go into a situation where we might be patients ourselves. And I stress this a lot because you might be on the freeway, you might be in the middle of a crowded parking lot, right? Some parking lots in the city of Los Angeles, it's not really a parking lot, it's more of it's like an additional highway, right? People speed through it all the time. You want to make sure that you're safe. If you're parked somewhere, you want to make sure that you're protecting your own environment. You want to protect yourself and your partner to make sure that you're able to conduct what you need to do safely for the greater good of everyone there. Any environmental hazards, right? Are you getting activated because of an earthquake? You have to make sure that, if you get from point A to point B, all your roads are going to be clearly accessible. There's nothing that's going to be blocking your way. You're not going to get hurt. There's not going to be any falling debris anywhere that you are. And there's just, especially if it's on, like I keep stressing, the highway, right? The highway is one of the most dangerous calls that we can have because there's a lot of moving cars and cars aren't paying attention to pedestrians or just people in general. So if you happen to be on the freeway, make sure you stop and really assess your safety just to make sure you don't get hit. Number of patients. This is important because we want to be able to give the best care that we can, right? And if you're the only one there by yourself, if you have a few people there with you and the team leaders there, you're able to handle if you have a few patients, right? You can conduct a scene size up, you can do your initial assessment. But if this is starting to become more of an MCI, then you would have to start triaging them, right? Which we'll talk about later. But then that becomes uncomfortable because you only have so many hands and you want to be able to control what you can. And that's the only thing you can control is what you're able to do and what you're capable of. So number of patients is really important. You want to be able to identify early how many patients you have. And then the mechanism of injury, nature of illness. Mechanism of injury basically just describes how and with what forces and with which body parts are injured, right? It's a tool that we use to gauge the type of injury that our patient might have versus what the call is, right? Are we expecting a broken elbow? Are we expecting head injury? Depending on the call, depending on how that incident occurred, whether it was a fall, if it was a car accident, if it was a gunshot or somebody dove into the pool and hit their head, the mechanism of injury would differentiate the type of response and the type of treatment that we do. So it's just early indicators of how the whole call is going to go and how we gear our assessment and our treatment towards that. So any additional resources? This falls in line with number of patients, right? If patients need to go to the hospital or they need paramedic intervention, call 911, let your team leader know. They can let the incident commander know. And everything just kind of spirals from there, right? Everything starts from the top and then the better your scene size up, the better your incident will go, and the better you're able to affect change for your patients. And the need for spinal immobilization, right? Is the accident or trauma so significant that you need to take precaution in protecting their spine by holding manual stabilization? It's just something to think about when you're conducting your scene size up. Anyone have any questions so far before we move on to the next section? Sounds good. All right, we're going to be talking about our primary assessment. So within a primary assessment, also known as the initial assessment, we want to identify and treat life-threatening conditions, right? This part of our assessment focuses on our level of consciousness, our LOCs, our airway, breathing, and circulation. It's pretty much the bread and butter of a primary assessment. You want to be able to form your own general impression of your patient, and then you want to determine that priority of care, right? Whether you can handle it at your level or if you need more advanced care, like the needs of paramedics or doctors and MD if they need the emergency room for surgery. So with your general impression, you are basically just observing appearances, you're observing their hygiene, observing the patient position, where they were found, right? Were they sitting upright? Were they sitting on the couch in a tripod position because they were having trouble breathing? Were they standing up, kind of acting lethargic, not being able to hold themselves up and they have to lean against the wall? All the sounds and the smells, everything kind of plays a part into your general impression of the patient. General impression is very subjective, right? It's what you see, what you hear, what you smell, and what you think is going on before you even talk to the patient. You kind of get a general impression and then you talk to the patient to get the chief complaint. Those two go hand in hand because sometimes it can be completely off and then sometimes you're spot on. And then just, as always, when you find a life-threatening condition, if they're not breathing, if they have external bleeding that you can control, manage their airway, control their bleeding, that has never changed. If you can affect and treat their airway, do that first. If they're bleeding uncontrollably, control their bleeding first, because we're not going to be able to do much else if we don't get those under control. So this is one of the most important parts, right? It's establishing the patient rapport. When we get called or if we show up to an incident and we're trying to help somebody, they might not necessarily know who we are. And it's kind of weird if we just go up to someone and start touching them and grabbing them and, you know, grabbing their hand and feeling their pulse, right? We want to introduce ourselves. Some of the most common questions, and this is the order of operation that I always go, I always introduce myself. Hi, my name's Andrew. I'm a firefighter with the city of Los Angeles. And what's your name? You know, I want to get to know them. I want to make sure that they're oriented. I want to make sure that they're alert and they're able to answer their questions. By asking all these, I can pretty much sum up if they're A&O times 4, right? I can tell if they're alert and oriented, and I can tell if they're able to respond to my questions. And then from there, I can go on with my secondary treatment as well. I ask them, hey, why do you call us today? That gets rid of the chief complaint question. When you ask that, pretty much whenever they answer you, they usually tell you what's wrong, right? My chest hurts. I have a broken leg. My leg hurts. Well, that's the most common one. Our back hurts, right? And then most importantly, we want to obtain permission to treat. We always want to obtain permissions to treat because we never want to put our hands on someone that doesn't want to be treated.
Yeah, the main thing is that permission to treat is huge. Mainly because if you don't get the permission, that's an assault. So that's very, very big, whether it's their personal preference or it's a religious belief. So it's extremely important to make sure that you get permission first, okay? It's huge.
And I was talking about A&O times 4 being alert and oriented earlier. So this is exactly what we're talking about, right? We want the person to be alert and oriented to time, to the person, to the place, and to the event. And this basically just all stems from them being able to answer simple questions, right? At any given time of day, whether they're sick, whether they passed out and they just woke up, or they're feeling really ill, you should always know about roughly what time it is, whether it's the morning time, if it's lunchtime, if it's around dinner time, if it's nighttime, right? You always remember your name, or at least most of us do, and you kind of always know where you are, right? These can get a little subjective. I like to ask, hey, do you know what city you're in? Or do you know where you are? If it's a school or you're at work, those are always common questions that we like to ask. And then the event, right? What happened? They might not always know what happened. They just might tell you, I passed out and I don't remember anything. That is an event that happened, right? They lost consciousness and they didn't remember what happened. So if they're able to answer all these questions, they are considered what we call ANO times 4. They're alert and oriented person, place, time, and event, right? If they are only alert and oriented to 3 of them, 2 of them, or even 1 of them, they might be alert, but they might not be oriented. They might be oriented, but they might not be alert. So they're interchangeable. It's just depending on how you want to ask your questions.
I have a question.
Yes.
So when the fact that they call you, you cannot assume that they want to be treated. You still have to get permission first.
For us, yes. And then even for you all as CERT volunteers, right? If you get called to an incident and we need you and you have patients here, especially during MCI, you always want to introduce yourself, right? And then you always want to ask if you're able to treat them, if I can help you. And just by doing that, it's a verbal consent and that should suffice, right? But if they're passed out and they're not able to answer your questions, with implied consent, it's implied that if they're conscious and if they're able to make their own decisions, they want you to help them. So even though you can't answer they can't answer your questions, it's implied that you have their consent to help treat them.
Oh, okay, thank you.
Yeah, the other thing is like, when we get a call, by the time we get on scene, that may change. So they may change their mind of whether they need help or not, but everything's incident driven because it might have some sort of different mechanism of injury to where they're afraid to tell you exactly everything that happened. So things can change once you get there when they call for help.
And they may not be the one who called you.
Exactly.
Good point. Okay, thank you.
And they can always withdraw consent at any time. So if you're creeping them out because you're not, you're dressed kind of grungy or you smell or something, they can say they don't want to be treated by you, at which point you have to stop.
Absolutely. And just by that, you can always just get somebody else or somebody else can step in, right? We're all part of a team. We're not doing this alone. So
Yeah, there's also a lot of times where we have calls where it may not be appropriate for a male to be there assessing the situation. So we need to change that to make them feel comfortable.
all right, moving on. So we're going to be talking about assessing stimulus responses, right? This is mostly for determining whether or not your patient is alert, right? And what they're alert to. So are they talking to you? Are they tracking you when they talk to you? And are they sitting in a room, sitting in a chair, and they're looking at you, walk to them, right? Are they only alert to verbal? If you say, hey, what's going on? And they grunt at you or they mumble some words, they're alert to verbal only, right? Vice versa for pain. P, if you do a pain assessment and they grunt or they moan, they don't really say anything, that's when they're only alert to painful stimuli. And then if they're unresponsive, right? This is the mnemonic that we like to use to assess that stimulus response. And it's just a tool that you guys can use as well. It's just to keep in your back pocket. So going on and moving on to our ABCs, airway. Airway is the most important, right? Is this airway pain or obstructed? Is this open or closed? Do we need to perform a head tilt chin lift? If you guys can recall from doing the head tilt chin lift from when we learned in our CERT classes, you want to tilt the patient's head back by pushing down on the forehead. And then you want to place the tip of your index finger and then the middle finger is underneath the chin and then pull down on the mandible, which is the lower jaw. And this lifts the tongue up and then improves the patient's patency of the airway, right? It keeps it open, keeps the tongue out of them, and then we're able to help breathe better. Now, is there a question?
I've got a question.
Yes.
You mentioned earlier about the danger of spinal injury and assessing for that. Will you have assessed for spinal injury before you do this?
Yeah, so if the need for spinal immobilization is based off of the mechanism of injury, right? If they're in a car accident and they complain to you that they have neck pain, yeah, you want to make sure that you probably put a C-collar on them, right? And then by that, if you need to open up the airway, you would do a jaw thrust. If they're unconscious on the floor and there's nothing really around them, did they pass out and hit their head? Did they just pass out?
I need to get back into the video.
I'm sorry? So we don't really know, right? So then again, you would consider
There we are.
you would consider it then as well. But yeah, no, you would consider spinal immobilization before you do the airway.
So if you're not sure and the person is not breathing, you're kind of in a bind.
Well, if you're not sure, just open up the airway, right? Because we always practice and preach life over limb. If they're not breathing, you want to fix their airway. If you're going to paralyze them by opening up the airway, it's better that you save their life.
All right, I'm gonna restrict unmuting. Let's keep all the questions until the end so we can get through the presentation.
All right, and I'm moving on to breathing, right? So breathing is important. We want to make sure that we check for rate, rhythm, quality, and depth, right? Are they breathing fast? Is it shallow? Is it regular? Is it absent? Is the rhythm regular or irregular? Are they in the tripoding position? Are they using accessory muscle use? Is their veins all distended out and it looks like a big V, right? Are they using more muscles than what they have to by instead of just normally breathing? You want to note that and keep that into consideration, right? You want to check the air movement and seeing if they're getting good chest rise and fall. And then you want to make sure that they have good tidal volume, right? And just to kind of piggyback on that, tidal volume is essentially just the volume of air moved between one normal inhalation and then one normal exhalation. So it's just one normal breath, right? So it shouldn't really take you any effort to breathe. And if it does, then you take note of that, right? Do they need oxygen? Are they having trouble breathing because of a health condition? Do they have COPD? Are they smokers? It's all something that you can keep in mind, keep in your back pocket for when you decide you're ready to treat the patient. So then another question is, well, how do you count breathing? How do you know if someone's breathing regularly, right? For adults, the normal rate is 12 to 20 breaths per minute. And we like to count by doing 30 seconds, right? So you count how many breaths in 30 seconds, and then you times that by 2. And then with that, you're able to calculate how many breaths they have per minute, whether it's in the 12 to 20 range. And then that's important when it comes to triage, right? Because if we all remember during respirations, if it's greater than 30 or less than 30, we would consider them either immediate or move on to the next, right? So circulation, essentially, we're kind of looking for the same things as in breathing. We want to feel for pulse, right? We want to see if it's regular, irregular, if it's fast or slow, or if they don't have a pulse. You want to check their skin signs, right? Their skin signs tell us a lot about the patient and a lot about a person, about how they're doing. Are they in shock? Are they pale, cool, and diaphoretic? Are they hot, warm, and dry? Are they clammy, right? That'll tell you a lot about the patient and how they're doing and their response. And then this is where you would control any external bleeding if you see it. And then also you can check for capillary refill, right? Just by going over capillary refill, you want to press down hard on your the bed of your fingernail, or just hard, and then you want to let it go, right? It should take about 2 seconds for the color to come back. That's how you would check it. If you're worried about nail polish or if it's covered and you can't see it, you can press on the palm and it's the same thing. You just press down hard, and then within 2 seconds, the skin and color of your palm should go back to pink. And then going about how we check for pulse, right? An easy way to check for a pulse, we can either do the carotid pulse, we can do a pedal pulse, or we can do the radial pulse, right? And then the easiest one that I like to do, you can also do the 30 seconds, and then you multiply that by 2. What I like to do is I like to count for 10 seconds. So I count for 10 seconds and then I multiply that by 6. And then that way you're able to tell how fast it is, or if you're able to tell if it's too fast or if it's too slow. And that's what's most important. Disabilities and deformities, right? This is important because you want to observe for any abnormal body presentation. Are they sitting properly, or are all the limbs in the right places? Is their you guys all remember that, who's the ones that have taken the cert classes, the tug of war picture? If all the arms are in the proper places, right? So we want to make sure there's no deformities. We want to make sure that everything is intact and everything's working the way they should be. And just talking about body position, you're going to see a slide later that talks about the tripod position. If you notice the tripod position, you're going to know that they're having trouble with their airway, right? Is it open? Is it not open? By that point, if they're in a tripod position, they're having trouble breathing. You want to get them to breathe better by either giving them oxygen or by helping them breathe, right? That's something you want to take note of, is that it's a disability with not being able to breathe properly. So if we talk about neurological deficits, I like this picture because it's fast and easy to use, right? So signs of stroke, symptoms of stroke, right? We like to check for the face, arms, and speech, right? When you ask them to smile, is the face uneven? Does it fall to the side? Is it uneven? These are things you have to know, right? It's easy to see once it's prominent, but then you have to ask yourself, hey, this is part of your it's part of your secondary, right? Or part of when you ask questions about permanent medical history. Hey, is this stroke new? Has this happened before? Is this an old injury or an old deficit that has been here and it's never healed? And so we treat them differently versus if it's a new stroke, or old stroke, or if it's just something that's permanent damage from before. And that's important to know. Arm, when you put your arms up, does one droop down to the side? Usually when you put your arms up, you can hold them down, right? But if you have stroke-like symptoms, if you have them raise their hand, they're going to drop one immediately. That's on the affected side. So that's also an important tool you can learn. And then speech. When you have a stroke, you don't know you're having a stroke, right? You can be talking normally, but then what those around you will hear is just a bunch of jargon, bunch of mumbling, right? They will be incomprehensible words, and you're not going to be able to understand them. And then time. Time is tissue, right? Time is always needed, and you can never call 911 fast enough. So if you notice these signs, just make sure that you get them quickly to a hospital, but most importantly, you call 911, and so they can have paramedic intervention, so they can limit the amount of deficits they might have or may not have in the future. And this is the tripod position. This is what it looks like. Sometimes it'll be more pronounced. Sometimes they'll be hunched over more. And then you'll see like the sternocleidomastoid, the muscle right here around the neck, it'll flare up, get really enlarged. And you can see them use their accessory muscle use, right? It's like really engorged. And that's just them having trouble breathing and they're not getting enough air. It's like when you're trying to breathe through a straw. It's like that for them, and that's how it usually feels. It's not a really good feeling. And then you want to expose the chief complaint, right? If they're telling you that their chest hurts, if they're telling you their arm hurts, you want to take the shirt off. You want to roll their sleeve up. You want to see that they're not bleeding. You want to see that there's no punctures, there's no stab wounds, there's nothing going on there, right? The worst thing we can do to someone is if they're having chest pain and you think, oh, it's a medical call, and you don't expose their chest, you don't know if they're bleeding or not. I've been on a call before where we went on a chest pain person and my partner forgot to expose the chest, right? And when we got to the hospital, when they put the EKG on and they actually exposed their chest, they noticed a 1 centimeter hole in their chest, in the center of their chest. And then we found out that somebody ice picked them. It was a good thing we brought them to the right hospital anyways. It ended up happening to be a trauma center. So they were able to help him with his problem. But if we had brought him to somewhere else, we would have been in big trouble. And so it's just important to expose your chief complaint and to see what it is that they're complaining about, right? To not get complacent. You want to assess the reason why you were called in the first place or why you're treating them in the first place. And then from here, you can utilize your information gathered throughout your whole assessment, and then you formulate your impression, right? Do they have any life-threatening injuries? Do they need paramedic intervention? Can I help them on scene now and take care of their bleeding, take care of their airway? Do I need more help? This is where you kind of decide whether or not you can leave them be, you want to pass it off to a higher level of care, or just kind of set it and forget it, right? It's a good area to do that in. And then for us, we like to determine the level of transport care. Not so much for you guys, but just in case you guys wanted a glance at kind of how we do things. If it's a rapid medical or a rapid trauma, right? Are they super sick? Or can we stay and play for a little bit? Can we ask the questions that we need to get a better impression and better assessment for the patient? Or are their injuries so life-threatening that we need to quickly assess them for their injuries and then get them going to the hospital so that they need surgery or get them the care that they need in the hospital, right? Because we can only do so much in the field and we can only control so many bleedings. We can only head tilt chin lift them one time before we pronounce them, right? For triage. Any questions? All right, we'll move on to medical science. Sorry, I realized that Patrick had muted everyone. Just if you have any questions, just jot them down, and at the end we'll go over all of them for you. So for medical or illness, right? If this is a medical complaint, if they're complaining of chest pain, if they're having breathing, we like to use them on an sample, right? We like to find the signs and symptoms. We like to ask for their allergies. We like to ask for any medicines that they're on, any pertinent medical history. Pertinent medical history is important because it kind of determines how we treat them, right? Is this a new injury? Is this important to their chief complaint? Do they have heart conditions? Do they have high blood pressure? Are they diabetic? Is this the stroke that they've had new, or is this an old stroke that they've had, or if they have any recent surgeries? Those are all important questions to ask and to take note of for your overall patient care. And then the last oral intake, what do they eat last if they had anything, right? It's especially important if they are diabetic. And then their events leading prior, right? Pretty much just, hey, what were you doing before this happened? If their chest started hurting, were they exerting pressure? Were they using energy? Were they just sitting down and sitting on the couch and then all of a sudden their chest pain started? It's important to know whether it was based off of exacerbation on exertion or if it just happened while they were sitting on the couch. That's also important to know. And then when you're assessing signs and symptoms, we like to use the mnemonic OPQRST, right? Onset, what were you doing when this happened? Any emotional or any environmental factors that can contribute to the problem? Were they in a state where they were so in shock that they started feeling dizzy, they started getting anxious, or they started having these chest pains, or they started breathing, right? It's important to know what caused the issue, because if they were just sleeping in bed, or if they were just lying down and all of a sudden, whether they started having chest pain or they started having trouble breathing or their foot hurt or something happened that wasn't out of the ordinary, that didn't happen because of a significant injury. And that's also important to know, right? It could be a medical problem or a past medical history that we didn't know about. Provocation. What makes it better? What makes it worse? Does it make it better if you sit down, when you stand up, when you lie down? And what position was the patient found in? That's important to know as well. Did you find them sitting down? Did you find them in the tripod position? Were they standing? Were they just kind of lying around or standing around just in an awkward gait? It's all important information to know for your general impression and just your overall well-being of your patient. And then the quality of pain, right? Does this pain come and go? Is it constant or is it intermittent? And then what kind of comfort are you or discomfort are you? Is it like a crushing pain? Is it a squeezing pain? You can use all these symptoms, all these different qualifiers to pass that on to whoever you need to, right? So if you tell them that I am having, like as a patient, they're having severe chest pain and it's crushing and it feels like an elephant sitting on their chest, and then it comes and goes and it radiates from, which we'll get to later, it radiates from their arm to their shoulder or their shoulder to the lower back. That can be significant enough to warrant, rapid transport. So that's all important to know. And the radiation, right? Which part of the region is that pain located in? Like I said earlier, does the pain go from your hand and into your shoulder? Does it spread from that area or is it localized? And then an important question to ask is, have you felt this pain before in the past? Because we want to know if it's new or if it's ongoing, or if it's something that was fixed before and then now it's come back again. And then I always thought this was a funny slide, right? I always thought this was funny. You ask the severity. 10 times out of 10, when you ask this, they're going to say a 10 out of 10, right? Because they're going to be in the most pain that they've ever been in, and that's the reason why you're there, and that's the reason why they need your help. But I always thought this was funny. And then the time, what time or when did this happen, right? Was this something that happened just now? Did it happen last night? You try to sleep it off and then still continuing this morning? Or did this happen when you were exercising and then all of a sudden that problem arose? That's all important to know. It's important for your patient. And then vital signs, right? We like to use what's called Bell's RP as our mnemonic, and when we check for Bell's RP, we check for blood pressure. We'll take a normal set of blood pressure. We'll check their eyes to see if the pupils are equal and reactive to light. We'll check the lung sounds to make sure that they are indeed having a patent airway and that there's nothing inhibiting them from breathing properly. And then we'll check the level of consciousness at the time. We'll reassess the level of consciousness. The great thing and the funny thing about these assessments is that it's ever changing, right? Just because you get to your patient, they might be talking to you, they can deteriorate really fast. And just because they were ANO times 4 when you got there, they could change from that and then becoming lethargic, being really dizzy, and then lying down and then becoming unresponsive. And it can happen as slow and as fast as 30 seconds. And then you want to reassess their skin signs, you want to recheck their respiration, and then recheck their pulse, right? These are all indicators on you can tell if the patient's doing well or if they're in trouble. So checking on neurological status, part of it is the ANO times 4. You can check their pupils. You check their extremities by checking for circulation, motor, and sensation. And then in the fire service for trauma, we like to use what's called the Glasgow Coma scale, right? If you guys aren't familiar with it, I'll briefly go over it with you. It's a fun little tool that we use. Don't know if you guys will ever use it, but I thought it'd be interesting for you all to learn it today. This are examples of pupils, right? Usually when your pupils are healthy, they're round, they're normal, they're reactive to light, right? They're not delayed, they're not sluggish. They're not irregular, right? They're not, one side is dilated and the other side is constricted or pinpoint. They're not both pinpoint. You don't have a conjugate gaze. They're not staring off to some in some area. Granted, some people have a lazy eye or some of them have glass eyes. Those are specific to that patient. So you want to note that, right? You want to ask if they do have that, and that's part of their pertinent medical history. So then you can tell how their pupils are doing and how they're doing neurologically. So when we check for CMS in our extremities, when you're doing a rapid trauma assessment and you're checking for your upper extremities and your lower extremities, you're checking for circulation, you're checking for sensation, and you're checking for movement, right? So how do we do that? Circulation, you check for a pulse, right? You can check for a carotid pulse, your radial pulse, or a pedal pulse. If anyone's having trouble with checking any of those, what I like to do is for your carotid pulse, all you have to do is you take 2 fingers, your index finger, you want to place it underneath your jaw and then just on the side of your windpipe, right? From here, you just want to press down ever so lightly, and then you'll be able to feel your carotid pulse. And then from here, if you can't find it, you just move it around a couple centimeters up or down. But most oftentimes, you'll be right on the spot. For your radial pulse, this one could be a little bit tricky, but what I like to do is I like to look or pretend like I'm looking at a watch, right? So when I'm pretending I'm looking at a watch, I'm looking at my wrist. By looking at my wrist, I'll put 2 fingers on my wrist, and then I'll keep my palm open, and then I'll turn it to this side. And then by doing that, my index fingers will be in between my wrist and the bottom of my thumb, and that is where you should be able to find your radial pulse. And I've used that before in the past. It's worked before, and sometimes when I forget, I do the same thing, and it's worked out well. Pedal pulse can get a little tricky. I'm not going to show you guys, but you guys can all take off your socks and look at your toes. You can wiggle your toes for me. And if you look at your big toe, look at your big toe down all the way to your ankle, you'll see a tendon, right? That moves with it. So if you follow that tendon up to your ankle, You move about maybe an inch or two below that, there's a little V. If you press your 2 index fingers there, you'll be able to find your pedal pulse, and you'll get it every time. For sensation, we like to ask, can you feel or touch your toes or your fingers? And we'll most oftentimes do it blindly, right? So they won't be looking at it. If we're touching their index finger, we'll ask them, hey, which finger am I touching? And they'll be able to tell you. Same thing with movement, right? You can wiggle your toes. Can you press down on it? Can you push up on it? Those are all signs that we can tell if they're having a neurological compromise. So GCS is a little confusing, right? It's a tool that we use to basically communicate the level of consciousness of patients with either acute or traumatic brain injury. It's mostly for trauma, right? It's nice because we can identify changes to consciousness in traumatic brain injury patients. It's not something that we follow closely, but it's something that we like to use, and it's a good indicator of how the patient's doing, and hospitals always like to know. So if everyone can, take a piece of paper out with a pen and paper. And you guys are ready? And jot that down for me. So just make a graph with eyes, verbal, and motor, 6 to 1, all the way down. I'll give you a few moments to write that down. All right, so when we're assessing for GCS, we have a total score of 15, right? On the eyes, you're going to have a total score of 4. For verbal, you'll have a total score of 5, and motor, you'll have a total score of 6. So if we all start at the bottom, and we'll just go from eyes, verbal to motor, right? So it's easy for you guys to jot down and write down. What I like to do for 1, just write a 0 with a dash on the 0 in all 3 sections, eyes, verbal, and motor. And that basically just means that there's no response, right? There's no eye response, they're not looking at you, they're not responding to you, and they're not moving. And so the lowest score you can get is a 3, is a 1, 1, 1. Basically means that they're not moving, there's no response, and they're not talking to you. Moving up from that, on level 2, from going from left to right, from eyes, verbal, and motor. For eyes, you're going to write to pain. Verbal, you're going to write incomprehensible. And then motor, you're going to write abnormal extension. So if they're tracking you, are they talking to you, right? For their eyes, are they looking at you after you put painful stimuli, right? Sometimes they'll just look at you and then close their eyes. If they're incomprehensible, are they moaning? Are they grunting? Are they sighing? Are they not speaking regular words? That would all be considered incomprehensible. And then abnormal extension, basically that just has to do with if they're having severe spinal cord trauma, right? If their spinal cord is so severe, so much damage to it that they're not able to control their extremities. And so abnormal extension is actually called decerebrate, and that is when their arms are all the way extended out. I'll show you a picture of it later. And then we'll move on to the level 3. So for eyes, you're going to write to speech. For verbal, you're going to write inappropriate. And then for motor, you're going to write abnormal flexion. So inappropriate for verbal would be like if you ask them what their name is and they tell you it's oranges, or you ask them, where are you right now? And they say, horse. So something that doesn't make sense, right? If you talk to them and they look at you, but they're not really doing much else, they're not really, they don't really much have purposeful movements to that. And are they withdrawing or abnormal flexion, right? It's the same thing with the spinal cord injury. That's called decorticate, right? It's another spinal cord injury. What it looks like, it's just them flexing their arms and it's inside. So when they're laying down in a supine position, they're decorticate. They have a really bad spinal injury. And that's something that you can keep note of. Not something we can fix in the field. And then our last one, level 4 for eyes, it's gonna be spontaneous, right? Are they spontaneously looking at you? We move on to verbal. Are they confused? Are they promoter withdrawing from pain, right? It's basically just saying when you touch their arm and their arm's in pain, are they moving away from that when you apply painful stimulus? For 5, we're done with eyes, max of 4. So we're gonna go for oriented, right? For 5 for verbal. Are they alert and oriented times 4? Are they able to answer all your questions? Do they know where they're at? Do they know the time? And then for motor, are they moving to localize pain? Are they moving towards the body part where you put the painful stimulus? You touch them and they lean towards that. That's a good indicator to know because it might not be as serious. And then our last one for 6, the motor is just a base command, right? If you tell them to raise their hand, they'll raise their hand. If you tell them to scratch their ear, they can scratch their ear, and they're able to obey and follow commands. So when all said and done, if you have a perfect score, you have a GCS of 4, 5, 6 for a total of 15. And all that means is either they have no neurological deficit or it's extremely minor, right? 13 to 15 is about the range where it's minor damage. 9 to 12 is when it's more moderate, and then anything 3 to 8 is more severe, right? If they're 3, they're unconscious. But you can never have a score of 0 or less than 3. So then from here, we'll move on to our trauma assessment. And just a very basic trauma assessment, right? We talk about DCAB, ETLS, we talk about the deformities, the contusions, the abrasions, the punctures, burns, the penetrations, the tenderness, lacerations, and swelling, right? These are all something that we look for, and it's all something that we take note of. Stuff that we can fix: external bleeding, control bleeding, control the airway. We have an order of operation we like to do, right? We like to start from the head, move down to the neck, move down to the chest, to the abdomen, to the pelvis, to your lower extremities, and then you move on to your upper extremities, because that's when we can check for the back, right? You want to log roll them, and then you can check their back, and that way you're not going up and down on the patient, and it's just all in one fluid motion. So for the head, basically all you want to check for the symmetry of the face, right? You want to make sure that they don't have significant bruising around the eye, they don't have any blood, they don't have any burned facial hair, any nose hairs, any coffee ground emesis, or any basically dried up blood or vomit, right? These are all things you can take note of. You can check their pupils here as well if you'd like. For their neck, you can make sure that they're alive. You want to check their cardiac pulse. See if they're using any accessory muscle use, if they're having trouble breathing. Check for any tracheal deviation. If it's their normal trachea is just going to be in line down your chin. If it's deviated to the left or right, it could be cause for a significant injury. And then any subcutaneous emphysema. And all that is just air trapped under your skin, right? It kind of sounds like Rice Krispies when you press on it. And then you move on to their chest. You can check for lung sounds if you have stethoscopes and if you are able to. But for here, you can check for any second chest wounds. You can check for any subcutaneous emphysemas as well. And it's just to take note of, just for you to know and pass on the information to the firefighters that you'll be working with. Abdomen, we like to check for Dr. Germ is the mnemonic. Dr. Germ stands for distension, rigidity, guarding, ecchymosis, which is bruising, any rebound tenderness, or any pulsating masses, right? It's easy to check for all this if their belly is distended, right? If it's bigger than normal, if they have any fluid in their stomach, if it's rigid, if it's hard to touch. When you palpate their stomach, are they guarding it? Are they protecting it from pain? Do they have any bruising, any internal bleeding, or any rebound tenderness? When you push down with both hands, does it hurt when you press down, or does it hurt when you push up? Stuff like that will tell you a lot about the patient. And this is just for your information to know. When we check for rebound tenderness, we check for pain. We always ask the patient, where does it hurt, right? If it hurts in the left upper quadrant, we'll start from the right lower quadrant and we'll move our way to where it hurts, right? We always want to start the furthest away. A trick that I like to use, and this is just for your information only, everything on the right side ends with an R, your liver, your gallbladder, and then you just throw your kidneys in there, right? On your left upper side, you have your stomach, spleen, and pancreas. You have your appendix on your right lower quadrant, and then your large and small intestines on your left lower quadrant. Technically, your large and small intestines it's all encompassing in your abdomen, and it covers all 4 quadrants. But if we're just fixing it on one side, I like to throw everything on the left lower quadrant. And then of course you have your female reproductive organs as well in both quadrants. But like I said, it's just for information only. Just so you know, so you're having pain in your right lower quadrant. Is it appendicitis? Is it your kidney on your left and your right upper quadrant, right? Is it something to do with your liver? It's kind of a good indicator for yourself to know for if you're in pain yourself. But then again, we have Google, and that's probably the worst thing we can do is WebMD ourselves to death. I'm guilty of that as well, and that's probably something I should stop, but it's just a tool that you can use. Pelvis, all you really want to do is check for the stability of the pelvis, right? We used to rock the pelvis, but we don't do that anymore because it can cause more damage. You can check for incontinence, you can check for priapism. That can all stem from a severe spinal injury, right? But most importantly, you just want to check the stability of the pelvis. You can gently press on the pelvis. If they're in pain, you always want to suspect they have a pelvis fracture, right? And we'll treat them differently because with pelvis fractures, if we move them improperly, if we move them too fast, we can cause more injury and then they can bleed out. And then lower extremities, talked about checking circulation, checking motor, and checking sensation, right? So we want to check CMS in all 4 extremities. And then once you get to your upper extremities, you can log roll them and then check for any step offs, check if their spine is in line, check for more subcutaneous emphysema, and then check for any blood that's been pooling in their back. That pretty much covers rapid trauma assessment. And then we'll move on to triage and MCI, right? Why we're all here. So if we all remember triage is to do the greatest good for the greatest number of people. And you want to make sure that you start where you stand, right? By using a casualty sorting system, you're able to be fixed and focused. You're able to sort out the chaos and the confusion, and then you're able to identify and separate your patients, right? You're able to identify which ones are immediate, which ones are minor, delayed, or dead. And that's important to know because the most important timing in a triage is the first step, right? It's the beginning. How you set up your triage dictates how your overall treatment site will be. If you can triage your patients fast enough to render them care, the quicker they can get to a hospital, the quicker they can get the ambulance there, the quicker you can help fix their airway, help fix their bleeding, the faster and better response they'll have. And so the first step, you always want to start where you stand. You want to make sure your scene is safe. You want to stay calm, and then you always want to create a visual survey, right? Just by taking a look around in the room, in the yard, in the street, wherever you're at, you can tell about roughly how many patients you have, about how severe they are, and if they're conscious or if they're dead, right? Usually they'll be either screaming, they'll be walking around, they'll be crying, or they're just unconscious. And it's an important setup to know because then it kind of gives you an idea of what type of patients you have when you actually triage them. So we like to use the simple sort triage system, right? It allows us to triage and to sort out multiple patients within the first 30 seconds or less based off of 3 guiding principles. And that is respirations, pulse, and mental status, right? So by doing those 3, we're able to determine whether or not they need immediate care, or if we can hold off and treat those that need it the most. And then it allows us to open blocked airways and stop severe bleeding as soon as we can. So the 4 categories that we have are immediate, delayed, and minor, and dead, right? So for immediate, basically all that means it's just those that can't survive without immediate treatment, right? They have a chance of survival. You have your delayed patients who might require observations. They may not be as severe as the immediates, but they're stable for the moment and they're not in immediate danger of death. Minors are what we like to call the walking wounded. If you can hear my voice, come to me, right? They are okay. They might be in some pain. They might need medical attention, but not at this time. And then you have your dead. It's those that are deceased, those that are, their injuries are so extensive that they won't be able to survive with the care that they're given, right? The two things that we're able to do with them before is to open up the airway once and do the head-to chin lift.
Give them 2 chances.
Give them 2 chances, right? That's all we can do for them. And documentation. Documentation is important, right? If you didn't document, it didn't happen. If there isn't a triage tag around them, they didn't get triaged, right? You always want to keep track of what you do, and then you always have a scribe to help write down the information, because sometimes it's too hectic, it's too much for one person to do at a time, right? So we have these triage tags that we use to sort out our patients, and all it is these triage tags. They have a string around it. You can put around the patient's neck, right? You have your minors, your delayed, your immediates, and your dead. Depending on how they fall under, all you would do is you would rip off a tab and then keep that tab on and then put it around the patient. So if he's a minor, you leave the minor on and you take a tab off and you keep it in your back pocket. If they're delayed, you take one off and leave it on, right? At the end of your triage, you can go back and count how many minors do I have, how many delayed do I have, how many immediates, and how many dead do I have. And then from there, you can kind of sort out and correspond to your team leader, your incident commander. Hey, this is how many patients I have. I just want to make sure. Just keep in mind that these incidents are dynamic and they change constantly, right? So just because they were immediate at one time, they could have went to black. If they were delayed, they could have got to immediate. So things change. It might not always match up, but just keep that in mind. So
Those tags are $2 each, so maybe don't go out and buy a bunch of them. There's other options like triage tape that you can use, or you can get these wristbands from Amazon that serve the same purpose. But those tags are like $2.50 each.
yeah, and you make up a good point with the bands, right? All you would have to do is just wrap the color coordinated band around their arm, around the wrist, to keep track. And that's also something that you can utilize as well. But as far as like the fire department goes and what we use in the city, we'll use these triage tags all day long. But just keep that in mind. We also do have the triage tapes as well. And then you can never triage someone to death. It'll only be more beneficial for them. So for here, where do we start, right? The first step is that you always want to tell the people who can get up and walk, go to a specific area, right? If they can get up and walk around, they are probably not at risk of immediate death. And in order for you to make the situation more manageable, those victims can walk out. They can walk and ask to move to a better location, and that way you can treat the most immediate. And that way you just kind of get rid of all the clutter, right? And then we'll designate these patients as minor or green for the walking wounded. When we move on to respirations, we're talking about if the patient is breathing. So for here, you need to determine the rate, right? If they're breathing greater than 30 breaths per minute, then they're immediate. This just means that the patient's showing one of the primary signs for shock and that they need immediate care. If they're breathing and the rate's less than 30 breaths per minute, you can move on to the next step. You go on to perfusion, right? But if they're not, you know, open up the airway, you position the patient, and then head tilt chin lift, right? If you open up the airway and they're still not breathing, then you classify them as immediate, right? You don't stop, you don't go on from there. If the patient's not breathing, you do that. And then if you're still not able to open up the airway, then they're considered dead. But if you do open up their airway, then they're considered immediate. Did I say anything? All right. But then, yeah, so from there on, we'd move on to our next step, which is perfusion. From here, there's two methods we can use. We can use the Blanche test, right, which is basically just the fingernail deep press for 2 seconds. And if the color goes back within 2 seconds, it's good. If not, then they're immediate, right? If it's greater than 2 seconds, they're considered immediate. Another great method we can use is you want to check the radial pulse, right? That's actually one of the better methods that you can check because pulse is usually always present, and if they're not, then it's obvious, right? But if their pulse isn't present, then they're tagged as immediate. If it is present, you just move on to mental status. So all this is like a building block and kind of a guideline for how you treat your patients, right? If you come up to one of the tests and they fail it, then that right there is where they stand. It's going to be immediate. But then if they move on, if they pass that test and they move on to the next level, and then that level they failed it, then they might be immediate, it might be delayed. But then you never go on to the next step. You never go on to the next level if they fail the first one, right? If you started from respirations, if they pass, you go on to perfusion. But then they don't pass mental status, right? You can stop and start anywhere you'd like. Just make sure that you don't go on beyond any of that. So what I mean by that is if they're breathing and they're not breathing, you open up their airway and it works, but immediate. But if not, you just stop. You classify them as dead, and then you move on to the next patient, right? You want to do the greatest number of good for the greatest number of people. And if you're taking too long to address this situation or address an issue, then you're not going to be able to provide that same level of care for the next person. And all this is you're just trying to save as many people as you can. So when we move on to mental status, this is the last level, right? This is the last part of the test. This observation is basically done on patients who have adequate breathing and have adequate perfusion. You have to pass those 2 other levels before you can get on to mental status. And this is really simple. If a patient can follow your simple commands, then they're considered delayed, right? If they're unresponsive and they can't follow simple commands, then they're considered immediate. If you tell them to cough, you tell them to raise their hand and they're able to do it, then they're good. Pretty self-explanatory. It's pretty simple. And we like to use the Mnemonic 30 to 2 can do for this. So just a quick overview of triage. I know it's a little fast, but this system was basically designed to assist us in finding the most seriously injured patients, right? The immediates. You want to remember that as more rescue personnel arrive on scene, patients will get re-triaged and then they'll get evaluated further, right? They'll get further treatment, they'll get more stabilization, and then eventually they might get transported. Patients may be re-triaged as many times or as often as time allows, right? So they can get triage, re-triage 10 times if they're there for half a day, right? Sometimes these things can take a whole day. Sometimes it can go on to the next day. It just depends on the type of incident and how long it needs to be established for. You want to keep in mind that you might not be the first person to arrive on scene of a mass casualty incident of an MCI. If other rescuers are already on scene before you arrive or when you arrive, just be sure to report to your incident commander, be sure to report to your team leader before you go to work, right? Because when you show up to an incident, we're not going to know who you are. We're not going to know what you belong with. You're going to have your uniform on. You're going to have your vest on. You're going to have your helmet on or your hat on. So we're going to know your cert, but then we're not going to know which bureau you belong to. We're not going to know which team leader you belong to. And we have specific jobs for you, but then if you don't know where you fall under, we can't utilize you in those specific positions, right? And all those positions are based off of needs that the incident commander or the team leader needs to help assist the overall incident. And then just keep in mind that there's a lot of events happening on the same time, and it can be really confusing when you're there. And then just always remember, you're always there to do the greatest good for the greatest number of people. And if you don't remember anything else, just remember 30 to 2 can do, right? If you're breathing less than 30 or greater than 30, if you have greater than 2 or less than 2 seconds for your perfusion, and the mental status, then you follow simple commands. If you just follow those, you can get to your immediates and your delays pretty quickly. You have anything?
The other thing that I just want to point out to you is like, when we have our verbal, when we tell people to get up and get out, to give us more room and just take care of the ones that really need assistance. Everybody that gets out is minor, but they're going to be triaged again. So triage is continuous. But at least you know, once everybody's out, you know that you're gonna have at least delayed, immediate, or deceased. That's the only thing that's left, that should be left. So it narrows down the playing field very quickly for you.
Also, when you direct people to come towards the sound of your voice, have them go to one specific location and wait there to be reassessed. Don't just let them wander off.
So I know Patrick might have some verbiage that he wants to talk to you guys about. As far as my presentation and our presentation is we're pretty much complete. But if you have any questions, we'll be more than happy to answer them. But I'm not sure if Patrick has anything he'd likes to add.
No, I think it was a very good presentation. This is an advanced topic. This does expand upon, go beyond the CERT basic training. But I think this is good to see the perspective of LAFD, how they triage. And all of this is actually taught in basic first aid and even more advanced first aid classes. So it is something that I encourage everybody to take. You don't have to, but it is something good to know. If you have any questions, go ahead and raise your hand and I'll call on you. Bob. Did I unmute you, Bob? Okay. Go with Adrian. Oops, I'm sorry, I'm hitting the wrong button. COVID. Give me a second here. Okay, Bob, go ahead and unmute yourself.
Thank you. Am I unmuted now?
Yes.
Yes.
Yeah, thank you for an interesting presentation. Going back to the original question I asked, because I'm sincerely confused. You come across an automobile accident or something, and somebody is not breathing, and you seem to be saying that if you straighten the head out or pull it back, you might be able to get breathing back. Is that what you were saying?
Well, so if they're having trouble breathing and they're unconscious and they're not breathing, right? In this scenario, if we're talking about an MCI and a triage and there's more than one patient, then yeah, you would just head tilt chin lift and you would open up their airway. And if you weren't able to open up their airway, you would classify them as dead or deceased, and then you would move on to your next patient. In a normal scenario, a normal world, if this was just one patient, we wouldn't be doing a triage. If this was just one patient, we'd be doing everything we could to help sustain him and help save his life. If that kind of answers your question.
Yeah. Is it because the person is unconscious and the head is tilted forward that there's difficulty breathing? Is that what you're trying to tell me?
No, it could be a lot of things, right? It could be unconscious and not breathing because of a traumatic incident. It could be because there's something including their tongue. They could have been eating something while they were driving, and then while they were driving and got into a car accident, their food got lodged in their throat. So there's a lot of things that could go on, right? By opening up their airway, by doing a head tilt chin lift, basically, if they're
Okay, could you describe head tilt chin lift again for me? That's, I think, where I'm having the problem.
I'm sorry?
Please describe the head tilt chin
Yeah,
lift.
So all you're doing is you're depressing, you're basically putting down their forehead, or you're pushing down on their forehead and you're lifting up their chin. And by doing that, by lifting up their chin, you're taking their tongue away from their throat, away from the pharynx. And that way you're opening up the airway so that there's nothing including them, right? It's like when you're sleeping and you snore.
So you would stick your hand in their mouth and pull the mouth open
I
and
mean, you
forward.
can if you want. If that's what you want to do, you can. I wouldn't recommend it.
You might lose a finger on that one.
Yeah.
Yeah, you
Okay.
definitely want to just, like you said, if somebody's unconscious, they got knocked out, their tongue alone by itself can block the airway. So if you tilt the head back and jaw thrust, that pulls the tongue off the back of the throat, it opens up the airway. But if the person's been injured, even if they have a neck injury, if they're not breathing, they're going to die. So you need to open up the airway.
Okay, Adrian, go ahead and unmute yourself and ask your question.
Hi, yes, I have a question. Do you know when they will be hosting the EMR class? It might be a little irrelevant to this class, but I was just curious.
We're trying to get some scheduled. We don't have any planned yet, but we're working on it. All right, John Paul. Jean Paul?
I'm here. Thank you, guys. Good presentation. Hey, back to right after stroke, under sample, I got signs, allergy, medication. What was for P and L?
Yeah, so P would be pertinent medical history, and then L is last oral intake, what they ate last, if they had anything at all. It was important, like if they were a diabetic, it would be important to know when they had their last meal.
Excellent. And when you come upon a stroke, somebody that you think had a stroke, are you still treating that with an aspirin right away?
That wouldn't be our first line of treatment. We want to just identify first if they are having a stroke, right? The best thing you can do for a stroke patient is get them to the appropriate facility, the appropriate care as soon as you can, right? Because you have that golden hour of basically your best chance of survival for them.
Yeah. So would you recommend not giving an aspirin if it was happening in your neighborhood?
You can. It's still part of it. It's just, I would still do my regular assessment and just making sure that they are indeed having a stroke and it's not something that they've had lingering in the past before where it was a previous deficit.
I really appreciate your time. Thank you, guys.
Really appreciate it.
Sandy.
Hi, thanks again for your presentation. I have two questions and they're both related to the Glasgow Coma Scale. So my first question is, was the scale where it had the picture of all of the eyes, they're dilated or irregular or gazing to the direction, or is the scale the 6 through 1 and the eyes, verbal motor?
No, this was the scale right here.
That's the scale. Okay, so on that, I couldn't understand what you said for number 2 for eyes.
2 for eyes is just response to pain.
Oh, response to pain. Okay, and you see it in their eyes. Okay, and then what was row 6 under motor?
6 for motor was just they obey regular commands. They're just normal functioning adults, and if you tell them to raise their hand, they'll raise their hand. If you tell them to scratch their eyebrow, they'll scratch their eyebrow. They're basically able to obey and follow all commands that you tell them to.
Okay, thank you.
Thank you.
Yeah.
Hold on. Find out who's. Let's see who's unmuted. All right, Jeffrey, go ahead and ask your question.
I just wanted to put something out there. If people are looking to get an EMR certification, the Red Cross does the Rose Parade every year and gives free EMR trainings if you volunteer to work at the Rose Parade, which runs 14 first aid stations during the Rose Parade and does also first aid stations throughout the year. And I'll put into the chat the email of the guy you need to contact. Thank you.
Nice.
Thanks, Jeffrey. Sherman.
You spoke about breath rate, but what about pulse? If somebody has a really high pulse, 130 or something like that, should they be immediate because their heart is going crazy, or what would you do?
In terms of triage, you just want to. It really doesn't really matter if their pulse is high, whether or not they have one or not. But yeah, it's a normal scenario. If they're having a pulse that's in the 160s, that's not normal, right? So that's all definitely something that we keep in mind when we're treating that patient.
Yeah, because even just anxiety can make the heart rate go up.
All right, Robert.
I'm wondering when those of us who are inexperienced in these things come across a situation. I know myself, my heart rate is going pretty fast in a situation like that. I came across a situation, I could not tell whether the person was breathing or not. Their eyes were dilated. What if it's not obvious that they're breathing? What do you do to check?
So if it's not obvious, and by that, do you mean you don't know if they're breathing too fast or breathing too slow?
Well, frankly, I thought the guy was dead, but I called 911 and they asked me, "Well, did you push him? Did you touch him?" And I said, "No, I didn't." And once I did that, I guess the guy was on some sort of drug, but it kind of roused him. But I could not see any evidence of his breathing, and I realized and sometimes if my own pulse is fast, it's hard for me to detect somebody else's pulse by cardiac artery check and that sort of thing. But I was just concerned about how one checks for breathing if you don't see the chest rising and falling.
So if it's like not obvious, you can always you can put your hand on their stomach. You can put their hand on their chest. You can just kind of feel if they are breathing.
That makes sense.
It's a very subtle movement, right? You can also, I don't know if this is still relevant since COVID and everything. You can put your ear close to their mouth or their nose, and you can look, listen, and feel, right? You can listen if they're breathing, you can feel their breath. But most oftentimes you could be able to tell.
Yeah.
And sometimes I know it's hard, especially when your adrenaline's running, but you just do your best. But usually you're able, it's a good indicator of that. If you just do the look, listen, and feel, then you can always just put your hand on their chest or on their stomach.
Right. Thank you.
Carol?
Hi, this is Carol Broder. I just wanted to jump in because I do teach for American Heart Association. And if we're not talking in a disaster and you come upon somebody, if you don't see normal breathing in 5 to 10 seconds, unless you're trained to BLS standards healthcare provider, that's enough they consider to start CPR if you can't detect it and it's that difficult. You just look for normal breathing.
So then this is a question and open forum to everyone, right? What if you come across that person and they are breathing, but it's agonal, but it's not a normal sign of breathing? Are they still breathing at that point? And this is a question.
The consideration when we teach is that that's not normal breathing,
So
that
then
you need to do something.
Perfect.
Call 911 and start CPR.
Don't forget the AED.
Oh, yeah, absolutely.
Yeah, thank you. I don't know if that answered your question, but.
Sandy.
Under the breathing again, we had 4 considerations. One was depth, and on your slide you had tidal volume. What does tidal volume mean?
Yeah, so it's essentially just the volume of air moved between the one normal inhalation and the one normal exhalation, right? It's just your normal breath. It's just a fancy word of saying how you breathe and how you exhale.
Okay, thank you.
Thank you.
All right. Any other questions for our hosts or our presenters tonight? I'd love to give you both a round of applause. Thank you very much for this great presentation.
Hey, we just wanted to thank you and thank you for having us. We're excited to be here and hopefully you guys learned something. I know I learned something today too, so we appreciate your time.
Yeah, I think for those of us who have not taken and more advanced even basic first aid or more advanced first aid. If this is something that interests you, definitely reach out. It is something that we recommend. The basic first aid, the 8 hour, I don't think is enough. I think if you take it, it's a lot to cram in to one 8 hour period. And there's definitely classes that try and teach all that in a shorter period of time. But some of the more advanced classes like wilderness first responder or responding to emergencies or emergency medical responder is a great class to take for cert members because it teaches you to the level just below EMT. Emergency medical responder is actually a national standard. It's not recognized in California, but some counties like County of Ventura do recognize it. It's a baseline standard for first aid stations with the Red Cross. And as Jeffrey pointed out, Red Cross does offer it for free if you're in the LA area and interested in working the Red Cross, or I'm sorry, Rose Parade as a medical responder. That class does sell out very quickly, so almost immediately. Oh, Captain Gates.
Can you hear me?
Yes, we can.
Okay. Hey, I wanted to tell you guys, Firefighter Huang and Howard, great job. You presented a lot of great information. I just wanted to reiterate to everybody, you guys learned a lot of good stuff here tonight. But remember, if you come across a person who needs help, the most important thing you could do is call 911 if it's not already en route. So don't get caught up doing all this assessment stuff before you activate the EMS system. If they're already en route, great, continue with your assessment and do what you learned today. But the most important thing you can do is call 911 so the professionals can get there. Thank you, Patrick, for hosting this tonight.
Absolutely. Always call 911 and then do what you can with what you have. Any other questions before we let you all go? All right, Chin, Christy, do you have anything to add?
Just saying, I'm gonna say what everybody else has said tonight. This was a fantastic presentation. It's really good to see this kind of learning take place, and I hope to see more of it. And definitely, I loved having the participation of our CERT instructors. That was a winner.
Appreciate having you here.
All right, thank you, everyone. And next month, the third Wednesday of the month is going to be August 17th, and I'm going to see if we can get it on working with seniors and their challenges. Have a good night, everyone.